Now, without further ado, I will turn it over to our guest speaker, Bernadette Ebanks, Service Delivery Improvement Director with the Women's Health and Family Planning Association of Texas.
Thank you, Elaine. I'm so happy to be here today with our partners. I'm thrilled on behalf of WIFPAT, which is what we call the Women's Health and Family Planning Association of Texas for short. So I'll be using WIFPAT today. To be working with the campaign and all of you that are participating in the teen-friendly initiatives to make care more accessible in Texas. Many of you on the line today are part of both the Title X network and a part of this important initiative. The tenets of both are to ensure that teens and others can be welcomed into your clinics and receive the services that they need in a manner that allows for autonomy, information given without bias, and for them to feel comfortable and heard. Before we jump in, for those of you that don't know me, I've been leading the QA/QI efforts at WIFPAT since 2013 and have had the privilege to go to hundreds of clinics throughout the state in a variety of settings, from working with small freestanding sites with 3 employees to major hospital systems with thousands of staff. Today, I would like to share some of the lessons learned and common themes I have found throughout, no matter who you serve, how your clinic is set up, or how big your staff might be. Okay, before jumping into the learning objectives, I want to highlight a few of the reasons why efficiency is so important as an overarching theme. When you're more efficient, you can increase the number of clients seen. And in Texas, the reason this is so important is because there's contraception deserts, as well as very limited access for certain parts of the population. So increasing access for the 1.8 million people in Texas that are uninsured is a win-win for everybody. Other than that, higher client satisfaction is found when clinics run on time and when people get what they need. And apart from that, billing is more effective when you're efficient as well. So today, at the end of this presentation, you'll be able to talk through strategies to engage and motivate staff to improve clinic efficiency, improve the client experience by making your clinic feel like a home, translate best practices into working smarter, test change to see what works in your setting, and know where to find the resources that you need. Okay, so whenever I talk about making any change in a setting, the first thing that you have to talk about is staff. I always start with the staff when thinking about making change or improving on what we are already doing. Staff is the lifeblood of our clinics. They are the pumping heart of what we do. In my experience, most people are willing to make change when they feel they have a shared core values, understand the why or the goal, and know what success would look like, when there's a clear roadmap where people can get feedback. Is it working? Is it not working? And check-ins are offered often where people can get feedback. Are appreciated, verbal acknowledgement, employee recognition, and staff appreciation. So how do we actually put that into practice? Okay, so the first thing I want to touch on is shared values. This can be done in a variety of ways, but regardless of how you choose to do this, remember that staff need a container to feel safe, heard at all times. Staff activities or exercises can be integrated into staff meetings, weekly huddles, daily huddles, or even an idea jar where people can make anonymous submissions. An example that can be asked is, when I come to work, I want to be blank. To integrate the client perspective, another question that can be asked, when I go to my healthcare provider, I want to be treated like blank. An example of this question is, when I come to work, I want to be heard and feel safe. To integrate the client's perspective, another question that can be asked is, when I go to my healthcare provider, I want to be treated in the same way. Generally, what emerges are that most people share the same values and will apply to your teams and the clients you serve. This is a solid foundation for approaching the work. Number 2, inclusivity. Being inclusive is not limited to your forms or your EMR templates. True inclusion comes when individuals are asked to bring their unique perspectives and lived experiences to the forefront, and anything from policy development to improving clinical care. Both language used and the direct environment can affect if people feel safe for both staff and clients. Next is information sharing. This is something I hear from both very large organizations to very small ones. It is extremely easy at the height of very full days not to share information both from the top down, but also in other directions. Generally, most people function with greater ease when they are operating with the most up-to-date information possible. A few ways to keep people informed and engaged are: share data. Most of your agencies have EMRs that can generate reports. Use it to tell a story. Let staff know what was accomplished each week or month in your clinics. Another strategy is having daily or weekly huddles. This is what I call eyeball to eyeball time. Start with something that is going well, something that you notice the team is doing, something to be proud of. Use the popcorn method or others and let everyone share one thing. After, repeat the process with something that needs improvement. Remember to keep this general. Do not use a huddle as an opportunity to call out individuals. Keep that with one-on-one. If this is not possible, consider email updates or blasts that are short and succinct and that also offer some inspiration. Lastly, and most importantly, is appreciating staff. Appreciating staff is crucial and important. Agencies that invest in staff in turn have better client care and less staff turnover. When people feel appreciated and seen, they will work harder and smarter. This could be done during staff huddles, formal acknowledgement, taking 5 minutes to write a thank you note or an email, staff appreciation and team building with gift cards, gatherings, or food. Okay, so now we're going to move into a few things about your clinic setting. And these are the components that I've learned that can make a clinic feel like a home. So again, I'm going to start with staff because everything begins and ends there. In terms of responsibly for setting the stage to be successful, acknowledging that most people feel intimidated or self-conscious when entering a clinic. This can be even more true when it comes to adolescent clients, possibly seeking confidential care for the first time, full of questions and uncertainties. Staff can be friendly and welcoming, model respect for individual privacy by not talking about other clients in common areas, not using personal cell phones on the clinic floor, offering help and assistance when people seem confused or nervous, and demonstrate understanding and empathy. Staff need to be bilingual or make translation lines available for people who have limited English proficiency. Moving on to the physical space, I like to frame this when I think about myself going to my healthcare provider, what makes me feel good, what experience do I want to have? And those are the same kind of things that we like to be thinking about for our clinics. So creating a physical space is instrumental in making sure each client feels comfortable. These are the things to consider. Is the clinic space clean and comfortable? And how is the seating designed in the waiting area? Is it in rows where people have to look directly at each other? Or is there some areas for privacy? Are there places where people can charge their phones? Is there water in the waiting room? What are you doing for people to make them feel comfortable while they wait? Another thing that I've noticed across the state is there's a big variety in the restroom. So thinking about inclusive signage to keep people feeling comfortable, making sure that restrooms are clean and that there's menstrual products for people that might need them, that there's also condoms available for people who might not want to talk about that in their encounter, but they can get them anonymously in the restroom. Thinking through in the restroom, you really have a captive audience. So what can you put in there that you really want people to see? I don't think it's a bad idea to have a patient's bill of rights in your restroom, as well as other signs about some social services that they can call if they might need help. So this could be sexual assault, domestic violence, human trafficking, any resources. This could even include food resources, food pantry resources, anything that a client might feel too embarrassed to ask about in the encounter. So really think through how your restrooms are set up and what can you do to make clients feel comfortable and have access to resources while they're in there. When information is shared in this space, think about, is it confidential? Do you have a closed door? If you're working in some kind of, if you're improvising and you have kind of dividers rather than closed doors, think about not doing sexual health risk assessments in those settings, but make sure that there's a closed door. Just keeping in mind as we close this slide out that this is a very, very personal visit and very personal information is being asked. So think through, if you were asked these questions, how you would want the environment to feel. And then in terms of safety, I want to again just stress that staff are non-judgmental and use language that is easily understood. I've been in many, many encounters where I've observed providers and staff asking questions in a manner that is not easily understood. So even using the word confidential might not be something that you do with every client, but you really gauge where the client's coming from. For adolescent clients, thinking through separate entrances and exits. In smaller communities, this can be really tricky because confidential visits are very hard in clinics that are in small towns. So you want to make sure that clients can enter and exit in a private way. Again, the intake process needs to be somewhere that people feel safe, that there's not staff coming in and out or barging in, that it's a private space. This is a plug for some confidential contacts. So in all of the forms that you give your clients, making sure that there is space to say, you can only contact me here. Making sure that there's a kind of a safety plan for people who cannot get mail to their house or other things. So really kind of putting that into practice. Another thing with teens in terms of safety is really outlining everything that's going to happen in the visit. So no surprises. If they've come in with something, making sure that you explain to them exactly what you're going to need to do to get them what they need. And really just narrating throughout the visit is going to be helpful for the feeling of safety. Okay, we're moving on to client-centered care. This is a word that has emerged over the last couple years. There's a lot of interpretations of what client-centered means. And so I just want to kind of go through some processes that you can do to support this kind of care and kind of just take some of the mystery out of it. So most people think that being client-centered means longer panels for providers, resulting in fewer clients seen, leading to reduced capacity. When in fact, changing a few small practices can result in increased availability. So I've trained with a lot of different providers, and one comment that came out was, I can't really have a tea party with every client. So what that means is like that the counseling session can't be so in depth that the services don't happen in this setting. So I just want to talk through a few things to consider when you're thinking about client-centered care. So it really starts from the moment a client picks up the phone to make an appointment to the frontline staff that they see in person when they walk in the door. So providing templates for determining as much as possible what the client is coming in for. So this means basically the way that pairs are set up and the way that encounters are set up is very conflicting with usually what people want to happen in the encounter. So as much information as you can get on the phone or at the front desk about what the client's actually there for, that'll really help determine the kind of panel is open for that client. So using the free text message services to confirm appointments the day before, same day, or 2 hours before, this allows clinics to determine and to prevent their no-show rates. So essentially being able to keep walk-in slots open and to know as late as 2 hours before if a client's not coming in. So this is super helpful. Secondly, creating a clinic flow with the least number of stops. For example, if pre-counseling and vital signs can be done at the same station, this will eliminate the transfer of the person and the wait time between each station. So the fewer stops a client can make in their visit, the more efficient you're being. For contraceptive visits, utilizing the family planning guidelines issued by the CDC. These are the quality family planning guidelines that were issued in 2014, and we'll have some resources at the end to outline all of that. But in those guidelines, they discuss something called the quick start method. And that means that somebody can come in and on the same day leave with a method right then and there. And so we will also provide you with some of the medical guidelines that go along with this. So when you utilize the quick start method, it allows the clients to get birth control the same day without the requirement of a full physical exam unless medically indicated, while setting up a follow-up appointment for a client to return. And this is somewhat tricky with billing depending on your agency type. But this basically means that if somebody does not want to get pregnant and they come in today for birth control, that they do not leave without something to protect them from becoming pregnant that is more effective than a male condom. So practicing true client-centered counseling will allow each provider to quickly determine the needs and preferences of that client. For clients that are using an established method, best practices as outlined in the QFP are to prescribe at least 12 months of that method. And this can be pill, patch, ring. And this creates efficiency by eliminating the need for frequent follow-up visits and opens up additional panels for new clients. Additionally, this increases the likelihood that people will maintain their method of choice if they are adequately stocked. So we've heard a lot that individuals coming in that had a lapse in birth control compliance usually was a result of not having a renewed prescription or forgetting to pick up a prescription, so that we know if clients have that on hand, then they're more likely to maintain their method. I want to jump in quickly about pre-counseling and distribution of emergency contraception in the event of a method failure. So this is a best practice, again, outlined in the Quality Family Planning Guidelines that allows providers and counselors to talk through emergency contraception with people actually before they need it. So this is counseled on and distributed so that if people do have a method failure, so in the event they forget to take several birth control pills subsequently, or if they have a condom break, that they have emergency contraception on hand and ready to go. And this is best practices to counsel both for female patients and for male clients, including non-binary individuals. So essentially what that would mean is that you would pre-counsel on that, and in the event they did have a method failure, then they would not have to come back in and get an appointment or find availability for emergency contraception, but they would have that on hand. So this does tie into clinic efficiency because that would continue to keep open panels for new clients. Many sites have dedicated a teen cell phone line with clinic staff taking call hours for that hotline. This has been done in bigger sites and in smaller sites. This has been extremely helpful for teens who are starting on new birth control methods. So for example, if a teen gets a LARC, which is a long-acting reversible contraceptive, but if they were to get that and within a week or two were experiencing cramping or spotting, they could call somebody and ask them questions about what's normal, what's not normal. They could also ask them if they wanted to get it removed and when they could do that. So it's not just about maintaining a LARC, but it's really about being able to answer common questions about side effects for adolescents, so they have somebody knowledgeable to go to. Often adolescents will turn to the internet if they're experiencing symptoms or side effects that feel uncomfortable or scary. And this can often lead to taking the IUD out themselves or resorting to things that are dangerous. So this is a really, really effective way to make sure people are happy on their method, to answer questions factually, and to also set up appointments to bring them in if they would like to try a different method or if they'd like to stop using the method altogether. So it's really just another resource to support adolescent health. Okay, so the next slide talks a little bit about how do you start to think about making change at your clinic site. So we have worked very closely over the last few years with the Family Planning National Training Center. At the end of this presentation, we will highlight several of their tools and job aids to support some of this work. So this framework is called the Plan, Do, Study, Act framework. And it really just provides some very simple ways to affect change at your site and how to do it in very small increments. So to really think through planning with your staff, how to execute it, thinking through what your goals are, trying it out, and then really kind of making small changes to figure out what's working and what isn't. So I'd like to just give a quick example of a case study. This was a project that we did with City of Houston over the last calendar year, and they are a very busy health department. This was done at one of their oldest clinics in downtown Houston, a clinic that had been there for 30 years. And when we started thinking through with this site what they wanted to change, there were some variables that we could not change, like the fact eligibility was on the first floor, and then the clinic and waiting room were actually on the third floor. And then they moved around the building several times to get what they needed. So first what we did was we worked with the staff and the leadership team to basically determine what our goal was for the project. And they decided that they wanted to see an increase of clients because the way that their services were set up was they were not able to see very many clients per day. And so after we decided that that was our first simple goal, increasing client capacity for contraceptive visits, then we used our clinic observation tool to basically follow several clients from the moment they stepped in the building to the moment they left the building. So we were able to take all that information from client observations to see what the wait times were, where the bottlenecks occurred, and we were really able to take that data to decide what we needed to do to make things different. So what they decided was they had 2 exam rooms to start, and they decided that they were going to convert 3 other rooms that were not being utilized into exam rooms for a total of 5 rooms. We also found during the observation piece that providers were not able to look directly at the clients when they were inputting into the EMR system. So we were able to purchase some consoles to make client-centered care work with an EMR. So providers could look right at the person when they were doing it. They could adapt to where the person was sitting in the room. So this was another thing that they decided to do. We are still in the study phase to see how these changes will affect their client numbers. So we're still kind of mid-project, but this was a process that we went through using this framework. And at the end of the presentation, again, I will show you some of those resources. Okay, so kind of walking through resources, and I'm going to pause for just a moment to do a poll. If we could just wait just a moment. We'd like to know, for the people on the phone that do work on clinic staff, do you all have weekly huddles with your team? And I'll give about 30 seconds to do that. Okay, before we dip into the resources section, I just want to give people time in the Q&A box to ask some questions. So if you have certain things you're wondering about, certain things through the WIFPAD experience that you might be wondering about our subrecipient network and some of the change that has been made, but we'll give just a few seconds for some questions before I dip into resources. Okay, so while we're waiting for some questions to roll in, I really wanted to offer some resources that have been super helpful for us as we've worked in Texas. So the first one is the Family Planning National Training Center, which will also see some further resources in a few slides. And then the Quality Family Planning Guidelines. These are both online. These are both interactive websites that will definitely help kind of offer a nice framework and the most up-to-date nationally recognized guidelines for clinical care in family planning for both adolescents and adults. Okay, so I wanted to introduce the contraceptive access change package. The link is also provided here. This is an incredible piece of work put together by the FPNTC that basically gives all of the tools, framework, resources, and training items that you can work with. You can do an assessment to find out where your site is now, and then you can also work with their interactive platform to train your staff, have benchmarks, and also do some evaluation. Next, for the PDSA resources, this is just a quick screenshot of one of the worksheets that they have provided. And this is a really simple worksheet that will help kind of just narrow down your goals and objectives to really kind of break them down into bite-sized digestible pieces. And then additionally, these are all from the FPTNC. I think I said that wrong. And these are the efficiency tools. So I just want to kind of go through each one. The patient visit tracking sheet is what we used at City of Houston to identify what some of the gaps were. And this will basically give you a really nice template that's already provided for you so you can use it, you can do it right away. The clinic efficiency dashboard actually is a calculator that will help you input data from your own clinic site, and it'll give you some information to how to make some changes. The clinic flow assessment partners very well with the patient visit tracking sheet, and that's going to help you kind of identify where some of those bottlenecks are. And it looks like I did the patient visit tracking sheet twice, so you have two. And then lastly, I wanted to share a case study that was done in Haven Health, which is in Amarillo. They are a Title X subrecipient. They also provide Healthy Texas Women, family planning, and breast and cervical cancer prevention programs. So they're with all the state programs in addition to Title X. They worked actually to do a quality improvement initiative, and this is a short video that you can watch. It's about 3 minutes, and this will actually take you through their initiative and how they did it. And then lastly, at the bottom, you'll see a training package. So this is an entire training package that hits on most of the things that I did today. It's much more robust. It gives very detailed directions about working with staff, timelines, and evaluation. So we'll wait just another moment if there's any questions, and we'll be with you in just a moment. So we just got a question that said, what is the most challenging part for clinics out of all of the moving pieces? You're going to hate my answer. The answer is money. In Texas, we are in a very unique situation where we have several different programs and we don't have expanded Medicaid. And so the eligibility requirements for each program, particularly in a state that has such a high number of undocumented people, I think the hardest thing is to work with administrators and financial folks at sites to basically have a concerted effort to make sure that you're covering everyone while offering high quality care. I would say that clients that have no funding stream, that is probably one of the biggest challenges. Okay, the next question is what ratio of MAs to NPs in sites? So that is a medical assistant and a nurse practitioner. What's the ratio? So depending on the agency type, so whether it's freestanding, a federally qualified health center, a hospital system, or a public health department, the NPs are going to be more expensive, obviously. So you want to basically make sure that you have a support staff that can do almost everything but the clinical care, so that you're really having supportive MAs. And I can't give a ratio, but I would say at least 3 to 1, possibly, depending on the size of your clinic. But I think that you really want to bill to the highest of the person's credential. So essentially what that means in a family planning setting is that you would have all the frontline staff and MAs do vitals, intake, and you'd really just have the provider coming in for the encounter. And that you definitely have an MA with the nurse practitioner in the exam room as well. You know, for an extra set of hands or anything like that, to really keep the panels 15 minutes or less. Okay, so the next question is, what's the ideal amount of stops? So again, I don't have a solid answer because all of our sites are set up so differently. But thinking through kind of if you're doing a blood draw, you really want to do as many of the vitals in the exam room as possible. And sometimes you do have to go to a lab to do a blood draw, but as many, I would say 2 would be ideal, but definitely no more than 4 in my experience. Okay, we're gonna leave the line open for just about another 30 seconds for questions, and then I will pass it over to Elaine.
All right, well, thank you all so much for joining us, and to our guest speaker, Bernadette, we hope that this has been useful for you. If any additional questions or comments do come up, our contact information is here on the screen. Please feel free to reach out to us. You'll also see in the chat box a link to our survey. Please do complete that. You can click on the link there, or you will receive it via email tomorrow. So please do be on the lookout tomorrow for an email with the slide deck and the recording and the survey, which again is required if you're seeking CE credits. If for any reason by tomorrow afternoon you don't see the email, please do check your junk mail folder in case it has ended up there. And we'd also invite you to check out healthytx.org for more tools and resources to help you make an impact around adolescent-centered healthcare. So thank you all again for joining us today during your lunch break, and we hope you have a wonderful afternoon.